going to summarize what every surgeon should know in the year 2020 about comprehensive genomic profiling. Thank you very much for accepting our invitation, Sai Vivek, and over to you.
Thank you, sir. And as sir was saying, the next 2 decades is going to be of precision medicine. So all of us need to know the basics when we are dealing with any oncology patient. And to kickstart, I think we'll be starting from the basics. And this is going to be the overview of our presentation for the morning. And any doubts, small or big, feel free to just type them out in the chat box, and we'll all discuss at the end of the session. So, overview of cancer. Yes, this is going back to the basics in DeVita. We all know our cell contains 2 chromosomes, which contains the DNA, and the DNA plus histone bodies form the chromosomes, and the DNA is nothing but their polynucleotides. So, nucleotide again is a nucleic acid plus ribose sugar plus a phosphate. So, and the genes are nothing but combination of these nucleotides which translate into a protein. So this is the basic structure of our genome. How changes in this and the translation is going to affect cancer, and how identifying these changes in the genome or the proteins or the RNA is going to bring out some targets in the treatment of cancer is going to be the essence of precision medicine. So again, different physical factors or different chemical factors can affect the genome, as we can see here on the slide. And this can bring alterations in the genetic sequences, which can lead to changes in what protein is translated in by the RNA, or what is transcribed to go into the protein. So again, carcinogens like radiation, viruses, and infections can be exposed to in our environment, and these can cause a lot of alterations that are responsible for carcinogenesis. So cancer, in short, is a disease of the genome. So how we are going to identify this, what are the methodologies that we have to identify these alterations, is what all of us need to know. So again, just to say, DNA, we know it is just polynucleotides, and these DNA are read and transcribed into RNA, which in turn are transcribed into proteins, and these proteins form the pathways. So as an onco student, we all know the RAS, RAF, MEK, ERK, which again leads to proliferation, the PIK3 and the PI3K, the AKT, mTOR again leads to survival. So the essence of all these pathways are the proteins. And where are the proteins coming from? They're coming from the RNA. And where is the RNA coming from? That's coming from DNA. So in healthy individuals, unaltered or unmutated genes produce healthy proteins that function in signaling pathways vital for normal cellular functions. So when there is an alteration at any level, so when genes are altered or mutated, the resulting proteins produced can have an altered sequence, structure, and function. So the RAS, RAF, MEK, that pathway proteins are unaltered, we have uncontrolled proliferation. If the PI3K, AKT, mTOR, which is one of the other major pathways, is altered, we can have uncontrolled survival. And uncontrolled proliferation and uncontrolled survival, as we know, is one of the hallmark of cancer, and that leads to carcinogenesis. Sometimes no protein or incomplete proteins are made, resulting in dysfunction of the pathways that we are talking about, and that ultimately leads to cancer. So altered DNA, altered RNA, altered protein lead to altered pathways, and hence lead to cancer. So our human genome is huge, but we know that only around 20 to 25,000 genes are the ones which are encoded for proteins. So amongst these 22 to 25,000 genes, only around 1.5 to 2%, a few hundred, are known to be involved in cancer. So the 2 types of genes that we commonly refer to are the oncogenes or the tumor suppressor genes. So either alteration in an oncogene can lead to increased proliferation, or a tumor suppressor gene, which is ideally supposed to suppress cancer, is altered. That can also lead to cancer. So now the area of interest is a few hundred genes which can be altered and which can ultimately lead to cancer. So only a subset of genes are relevant in oncology. So this is a very important slide, and all of us ought to know about this. So what are the four major types of genetic alterations which drive tumor growth? Very beautifully illustrated here. So again, as we know, this is a chromosome, again made up of genes. Let's say, for example, we are talking about a gene of interest. If we take this as a gene of interest, the four major classes of genomic alteration that can drive tumor growth are base substitutions. Again, we can see here the A is substituted by C. So adenosine is substituted by cytosine. So our A and C are substituted. Again, insertion or deletion. So then extra nucleotide is added or one is deleted. So this is a common example. Lung, all of us know EGFR mutations are present in lung to that level. So this is an exon 19 deletion. So copy number alterations, a classic example here. Again, the number of reads, the number of nucleotides is altered here, and that is a HER2 amplification. Gene rearrangements or fusions are the ALK fusions that we see in lung, the BCR-ABL that we see in CML, which is a very common thing and all of us need to know about it. And these are the rearrangements or gene fusions. So just to reiterate, this slide I think is very important for most of the students. The four classes of genomic alteration are base substitutions, insertions and deletions, copy number alterations, or rearrangements. So the latest technology that we are talking about is NGS. Everybody talks about it. I'm sure you've come across it in the last few years of your training. So what is this next generation technology or next generation sequencing? So if at all a DNA sample is sent to a lab, what happens to this DNA? First, they extract the DNA, and the DNA is made into fragments, or a library preparation takes place. Then an available probes are hybridized with the library preparation, and after adequate removal of the noise or the waste or what we don't want, the captured DNA is sequenced multiple times based on which lab and which amount of depth of sequencing is being offered, and then the sequences are mapped. Once these things are mapped, it is compared against a normal sequence that we know thanks to the TCGA and other genomic atlases that are available, and the abnormal versus normal is compared, and they call out the variants. So it could be just a variant of unknown significance, or it could be a pathogenic variant, or it could be a likely pathogenic variant. This is very important when we read a CGP or a report where a variation of unknown significance does not require for us to clinically act on it. Only likely pathogenic variant or a pathogenic variant is when we go through the available treatment options based on where in the natural history of the cancer we are doing this. Treatment can be suggested or treatment can be changed to include respected targeted agents. So again, this is the mapping of the gene to the genome, and this is how an NGS before the variant calling happens, this is how the raw data is available in many labs, and this is compared to the standard available normal genome, and variants are called out. So again, just if we remember the different steps of NGS, this could be a large question in our exams also. So a DNA sample preparation is the first step, and this leads to an adequate library or a QC. The quality control is added at this level. A library preparation is there. A cluster generation, sequencing, reference mapping, variant calling, and bioinformatics analysis. So these are the important steps in next generation sequencing. And once the bioinformatics is done, that's when the report is released to the clinician. And here, based on the available scientific data, we decide on whether to act on it or use it in the treatment protocols of our particular patient. So this, again, is definitely a slide which might be used or might be asked for in different exams. So just to recap the basics so far, we all know what is the flow of information in a cell: DNA, RNA, proteins. These proteins act in the pathways again for the normal homeostasis of any cell. So cancer is nothing but a disease caused by genomic aberration in which organizational level of the genome is altered at multiple levels. It could be at the level of DNA, it could be level of RNA, it could be level at which the proteins are made, and it could also be at the level of epigenetics, which we haven't spoken about. Epigenetics are basically the supporting structures which affect the way a gene is transcribed. So the four main categories of genetic variations that we saw are the amplifications, fusions, insertion deletions, and again we have the base substitutions. So the true attributes, so that is a question which we just discussed, so I'll be skipping that. So now with these basics, let's jump into what is comprehensive genomic profiling. So NGS is nothing but a methodology. It's a methodology by which we have the sequencing that is happening. So we all know in the past we just used to do a PCR for one gene, or we used to do Sanger's, we used to do FISH, IHC. We'll be going through that, but NGS is something which captures all these, or captures a lot of data in a short interval of time. Now, the next word that we are being exposed to here is what is CGP, or comprehensive genomic profiling. So like any camera, so I think in the last 2 decades, we have seen different camera resolutions that are changing in every phone. We have 20 megapixel, we have 10 megapixel. Like that, genomic technologies and their resolution are basically what differentiate the different diagnostic options that we have in the clinic. So different technologies have the ability to identify genetic aberrations in different levels of the genome organization. So if we see the single gene like PCR, what we use for detection of a single gene alteration, to MLPA, southern blot, CGH, FISH, spectral karyotyping and karyotyping, are different resolutions that we really see. If we see on the top of the slide, the different depths and resolutions. And next generation sequencing is something which really encompasses all these and leads to simultaneous sequencing of multiple genes, leading to information availability at a much faster rate, and where we can get a whole picture of what is happening inside in a cancer cell, that can lead to very important treatment decisions. So again, this is the evolution of it. So we started off with IHC, which is just at the level of proteins. If you're looking at a protein like HER2, simple breast cancer, ER, PR, HER2, that is an immunohistochemistry that deals with it at the level of the proteins. If you're looking at the level of RNA, or at the level of DNA being transcribed to RNA, and following which mRNA is translated, here again RT-PCR, that is real-time PCR, or RNA sequencing comes here. But if you're looking at the level of DNA, here we have FISH, the ISH methods, the PCR, and genomic sequencing. So this is again a very beautiful slide telling us what diagnostic test acts at what level, hence leading to valuable information. So we started off here. So IHC, FISH, PCR, that then we have the first generation sequencing. So people might be having a question, why is it called next generation? What was the first generation? First generation was the Sanger sequencing. Then we had NGS based hotspot testing. So hotspot testing is basically you pick a small panel only for lung. So you have EGFR, ALK, ROS, RET, NTRK, HER2. So these are hotspots. You're just picking a custom panel and then checking only for that using the methodology of NGS. Then you have comprehensive genomic profiling, to the definition of which I'll be going in the next couple of slides. So what is the meaning of comprehensive? It has to be a few hundreds, at least 200-300 genes have to be read, wherein we not only know which genes are mutated, we also know whether other mutations present in the genome have different interactions with the genes of interest. So a gene can be mutated, and if we know only that much, that is, let's say, 50% of the information. If we know the next gene which is mutated has implications on how this gene behaves, that is becoming more comprehensive and getting more information at one shot. Future is going to be whole genome or whole exome sequencing, where in research people are already doing it in many countries. So whole exome sequencing is definitely having much more information, but more information, we know the knowledge of all our clinicians has to catch up to that level. And with more, as they say, with more power comes more responsibility. So you need to be more responsible in understanding the implications and using that information in the clinic to adequately and timely treat the patient. So a very important factor here, as I just reiterating what we just discussed. So let's say we are trying to look for one particular gene. So a routine single marker molecular test as an IHC, PCR, or FISH that have been used for the last 2 to 3 decades will just find what has happened to that particular gene or that particular protein of interest. So this forms a single marker test. Now we go to the next category, or the second category, where we're using just a hotspot. So we might find only the areas of interest, the 5 or 10 that we are really looking for, and we would have missed so much of other information where changes in this gene might have an implication on what we found here, but that information is not there. Next, what is comprehensive? We really go ahead and sequence multiple or hundreds of genes, and we tend to know which are the pathogenic genes and what is the interaction between another gene on the pathogenic gene also. So this is comprehensive genomic profiling. So more comprehensive coverage will have more information. As we know, there is data for all this. So 17% EGFR, the common mutation in lung cancer, is missed in a hotspot panel compared to a comprehensive. So 26% of lung NCCN genes are missed when we are looking at only the hotspot mutations. So 50% of targetable alterations were missed using an hotspot NGS without supplemental FISH. So there are a lot of RNA sequencing also which is required, especially in the fusions, which can be missed if we don't select the correct test. Just having the drug in the world and us talking hours about it is not enough. Knowing which test to order for the patient, these are becoming much more cost effective than what they were 5 years back. Now they're much more accessible to different hospitals, but knowing at what point in the patient's diagnosis, what test we are ordering might make a difference between the patient receiving chemotherapy or the patient receiving a simple tablet or immunotherapy, which might definitely increase his quality of life many folds. So that again, every clinician needs to know which test to order at what point and what is the information I'm looking for. So any test, before we write it, we should already have in our mind what are the results that we are looking for and how is it going to change my treatment. So just writing the test is really not going to help the patient. It will only lead to more confusion rather than a good treatment decision. So this is a good slide again about comparison of different genomic technologies. This again might be a important question in the theory papers. So the ARMS PCR, the RT-PCR, ddPCR, Sanger sequencing, and NGS. So I'll briefly just summarize this so that all of us know what we are doing. So ARMS PCR is PCR primers specific to a particular mutation is used. So the method of detection is the agarose gel detection. We get the results really fast. So that is an advantage. The sample type here is tissue. So it covers 10 to 25 hotspots inside the EGFR gene alone. So we are looking at one gene. So then we have the RT-PCR, ARMS PCR or PCR plus TACMIN. Special probes are used where we get the result again in 3 to 4 days, and it covers a little more number of hotspots inside the gene. What are the hotspots inside the gene? If we take the EGFR gene, it will have different exons, exon 18, exon 19, exon 20, exon 21, and different mutations in these different exons can lead to different treatment implications. Then you have a ddPCR, where it's an emulsion-based amplification and probe-based detection. Again, a quick test, 3 to 4 days is what is the turnaround time. But here, this is done on either tissue or plasma, and it covers around 30 to 40 hotspots. The Sanger sequencing or the first generation sequencing, where the sequencing of the PCR amplicons by label ddNTPs, which again, within a fortnight, you get the result. Again, here, as you see, exon 18 to 21, and some amount of extra depth is there by the Sangers. And all of us have moved away from Sangers to the next generation sequencing. This is sequencing by synthesis, where within 2 to 3 weeks, we will get literally all mutations that can be possible in that particular gene. So simultaneous presence of exon 20 and exon 19 can have a definite treatment implication. And some of us might know that exon 20 T790M mutation, the most famous mutation, means you have to give only osimertinib. Only osimertinib will work in that patient. So having all the information about that particular gene can definitely help us in planning the next treatment. So if somebody asks, what is CGP? So there are different definitions. So CGP is a next generation sequencing approach that uses a single assay to assess hundreds of genes. So that is the most important thing, including relevant cancer biomarkers as established in guidelines or clinical trials for therapy guidance. So another definition is a simultaneous detection of all classes of genomic alteration across hundreds of genes with a single test and a single sample. This forward thinking technique was enabled by the advent of the technology called NGS. So, NGS is a technology, CGP is basically what we are using this technology for, and its ability to deliver ultra high throughput and scalability. So, multiple institutes and multiple bodies have defined CGP in a different way. So, the US Center for Medicare and Medicaid Services has deemed tissue-based CGP, which includes evaluation of, again, single nucleotide variants, short insertions and deletions, copy number amplifications and deep deletions, fusions, MSI, and tumor mutational burden medically necessary for patients with advanced solid tumors. So this, I think, would be a good definition to include, if at all asked in theory, what is comprehensive genomic profiling. And it ideally should be a multi-gene panel with more than 300 genes encompassing all the available biomarkers which are responsible for drug targets and major cellular pathways. And it picks up all classes of genetic variants, just as we discussed, the SNVs, indels, CNVs, and translocations. And unless we sequence hundreds of genes, we cannot talk about tumor mutational burden. So if we're talking about tumor mutational burden, we need to have a denominator. So what is the denominator? Again, it depends on the number of genes also. And microsatellite instability, which in the next few slides, we will know what is its importance and how important it is for a medical oncologist who knows that the microsatellite instability is high or low. And it covers the entirety of the gene. So again, EGFR gene is a classic example. If we just cover exon 19 and 21 and leave out 20 and 18, a resistant mutation in exon 20 will just not be picked up, and we'll be treating the patient with a simple drug with little or no response. So entirety of the gene coverage is again what is very, very important for us when we are talking about CGP or comprehensive genomic profiling. So the 4 simple benefits that we can talk about when we are talking about CGP is diagnostic value. You will know everything. So you will know the complete mutational profile of the cancer, and that information can be analyzed in a molecular tumor board, and a proper and well-informed decision can be taken. So we'll also have prognostic value. How severe is this cancer affecting the patient? We all know many cancers, a simple TP53 or a P53 alteration can lead to adverse prognosis. So it is of prognostic importance also. Therapeutic value. What are the possible therapies that can be offered to this patient? Predictive value. Now we know that this particular mutation means this particular tablet or injection or a chemotherapy is recommended. And we will also know, because of the information we have, whether this might work or is there going to be a quick resistance that might develop. So it's diagnostic, prognostic, therapeutic, and predictive. So these 4 words, if used in any answer for CGP, I think would be quite impressive. So it is just not about identifying biomarkers and choosing a therapy. It is a key tool to understand the biology of the tumor. So that, I think, is the most important point here. So for all of us, whether it is a surgical oncologist, medical oncologist, or a radiation oncologist, understanding the biology or the behavior of a particular tumor is very, very important. When we know whether to give treatment or not, whether to operate or not, and whether to expect a recurrence or resistance in the future. So that particular behavior of the tumor, in each cancer and different patients, the biology of that particular cancer might be different. So we all, simple example, young breast cancer versus normal postmenopausal breast cancer. With experience and knowledge, we know young breast cancers are more aggressive. So that again becomes the biology of the tumor. So understanding this biology is of paramount importance, and I think that's what differentiates us in the clinic about which oncologist is able to quickly pick up the biology of the tumor and suggest the correct treatment versus just treating by the book. So that is the going to be the clinching factor or the differentiating factor. So how do we understand the biology? One, by just clinical parameters, and two, by going into the genome and going into the comprehensive genomic profiling, understanding what mutations are present, how it is going to affect the future of this particular cancer is another way of understanding the biology. So the ASCO also has come up with a clinical opinion. They said at that point, this was again a couple of years back, so they said any patient with metastatic or advanced cancer should undergo genomic sequencing, and they say a multi-gene panel-based assay should be used if more than one biomarker-linked therapy is approved for the patient diseases. So in the next decade, we are going to see a huge shift in terms of how we are going to treat a metastatic cancer. It's not going to be tumor based, it's not going to be location based, it's going to be tissue agnostic. So we are going to treat the biomarkers and not the particular name of the cancer. So that is going to decide which treatment is going to be offered to the patient. So CGP enables something known as precision medicine or tailored therapy, which is going to be very, very important in the next 10 to 20 years. So again, what is precision medicine? So this slide beautifully illustrates that, as we see on the left-hand side. Now, as of now, we are treating all lung cancers, or we were treating all cancers with one chemotherapy. So breast cancer used to have ACT, so one drug fits all. Then we started differentiating it into one patient group or one biomarker is one drug. Let's say HER2 positive, this subset is going to get anti-HER2 treatment. Now, in the future, because of CGP, we are going to start moving towards one patient, one tumor profile, and we are going to have a single drug for this patient, and this won't be the same for the next patient. So that is precision medicine, or that is tailored therapy to each individual patient. And this is already there in metastatic setting, post 1 or 2 lines of therapy. We don't go by lung cancer or breast cancer, we go by biomarkers. And this is slowly going to creep up into first line metastatic. And we never know, in the next decade, it might come up into the adjuvant or neoadjuvant settings also. So good example of this, again, rectal cancer. As we saw last year, there was a lot of noise in all the social media about them finding out in MSKCC in the US about MSI high and treating that particular rectal cancer with dostarlimab. And post 2 to 3 years of follow-up, also the patient happens to be in complete remission without surgery or any other treatment. So that had come up in the neoadjuvant setting in the small trial, and that was possible only because of knowledge about CGP and picking up those MSI high patients. And that is what led to a small sample size also. They picked up only around 15 to 20 patients across United States, and that was the trial which created a lot of noise in rectal cancer. So if we are serious about treating cancer, it's best for us and best for our patients that we need all the information available and all the genomic data is available to us. And this forms an integral part of our treatment decision. So cancer or metastatic cancer is beautifully represented in this particular picture here. Think of the metastatic cancer as a 9-headed hydra, where the complexity and heterogeneity of a metastatic cancer requires us moving beyond the scripted monotherapies to tailored combination. So we need to know where different metastatic sites we need to understand can be of different clones with different resistance mutations, different pathogenic mutations, and knowing all the information before starting a patient on a particular treatment which might act on all the clones is very important. Otherwise, you give it a scripted therapy, you take out one head, the head grows back, or the other heads take over and continue the progression of disease. So again, customized or precision medicine is the way to go at this point for a metastatic cancer. And molecular tumor boards are the key for success. Not one person can know or interpret all the molecular mutations. So sitting in the molecular tumor board is only going to enrich our data, our knowledge about how each mutation, as we saw, at different levels of the genome is going to affect the cancer progression or the cancer treatment. So a molecular tumor board ideally should constitute different organ specialists, the genetic counselors or the molecular pathologists, and other even just pathologists to explain about IHC. And these people should sit with the information provided by CGP, discuss, bring out what is the pathogenic mutation, and hence decide on a proper treatment for that particular patient. So the therapy is off-label in metastatic settings. The testing must be on-label. We need to know what is the correct test for this particular patient. And every patient in our country also is going to be able to afford it sooner than later. Let's say 5 years down the line, we are talking about a CGP test which started at almost two and a half lakhs was where it started, and now we are looking at tests which are available for even 20 to 30,000. So that is the most important thing. So the availability and the cost is going to rapidly decline as we go along. So that makes it very important for us to know which test to order at what time. So every cancer patient should be profiled because the availability is increasing, costs are falling, and genomics will be very, very important. So this is the new era of clinical research. The drugs are approved for biomarkers and not cancer types. And guidelines may be just as important as regulatory approvals. So right target, right drug, once a clear benefit is there, FDA approval is coming in multiple cancer sites. So just in 2023, just concentrate on the right side of the slide. Look at the response rates, and these are heavily pre-treated patients. As we see, the different molecules that have been approved have excellent response rates in terms of how the patient's disease is being controlled after 3 to 4 lines of therapy. So these are all immunotherapy molecules, pembrolizumab, dostarlimab. These are again NTRK fusions. These are just targeted tablets. So again, these are becoming tumor or tissue agnostic. So we can use pembrolizumab for every MSI high. We can use entrectinib or larotrectinib for every NTRK fusion, irrespective of the cancer. And how are we going to find these NTRK or tumor mutational burden being high or MSI being high? Only because of doing a CGP. So again, tissue is a major issue for all of us, and getting the adequate tissue has been the point of discussion for years together. But thanks to liquid biopsies, which are getting better and better, especially in a metastatic cancer, where we are just able to capture a few ml of blood and do whatever we want to do in that particular sample, is something which is definitely revolutionary. And liquid biopsies will actually capture the tumor heterogeneity in a metastatic setting rather than a single site biopsy, because you'll have shedding of ctDNA from all the metastatic sites into the blood, which can be ideally captured. So I'm skipping this because again, this is nothing but IHC versus FISH versus the different technologies. So one thing we need to know, that just by doing DNA sequencing, we are not able to get all the information. So this is a very important thing. What MSK Impact is basically a test, like comprehensive genomic test called MSK Impact, like Foundation One. And what they found, that just by doing DNA, they found almost around 16% of the people had genes which were mutated in the level of RNA, not DNA. So you can miss if you don't include DNA and RNA sequencing, or a test does not include DNA and RNA sequencing. Many actionable mutations can be missed, and wrong treatment or inadequate treatment can be offered to the patient. I'm just going to quickly go through the common mutations, how they have changed, and how they have
Dr. Sai, sorry to interrupt. Dr. Sai, I think we lost the connectivity. Voice is breaking. Your voice is breaking, Dr. Sai. Just check your internet connection. Dear trainees, till the time you may type your questions, comments in the chat box. Dr. Sai, are you with us? Dear trainees, I think we have lost the connectivity. So you may type your questions, comments in the chat box till he joins. Thank you. Yes, Dr. Sang, you may start sharing the screen.
Yes, sir. Yeah, am I audible?
Yes, you are.
Yeah, sorry for that technical glitch. I had a power failure at my place, and I'll be continuing where we stopped. So I think
You may go to the previous slide.
yeah. So I think
One more.
Yeah, so I think
Yes,
we were just discussing about the different implications of this, and again, what we can see here is I'm quickly going to go through a few tissue agnostic mutations that might be of interest to all of us in our clinical practice. So one, RET fusions, as we know, are there in multiple tumors. So starting from an MTC to a colorectal to an ovarian, all of them might have a RET fusion. So this particular RET fusion, wherever it is there, it has an approval for a drug called selpercatinib. And what we can see here in the trials, just observe the waterfall. Just observe the waterfall plot here. There are sites of RET fusions where a complete remission can be brought by just this drug, selpercatinib. This is just to tell us that tumor agnostic or tissue agnostic treatments do work. If you see the response rates, majority of them have more than 50% response rates, and there are CRs also. So that is the importance of picking up this RET fusion where there are molecules available to get good responses. Similarly, with NTRK, which is even rarer, we can see it in many tumor sites, especially salivary cancer. So, salivary cancer doesn't have many other options. If at all it is advanced, not even chemotherapy works. So, you have salivary cancers, which are very important, secretory breast cancer, and many pediatric cancers also have this NTRK fusion. So irrespective of the cancer, there are drugs like entrectinib which are approved, and these are the brilliant response rates that we observe with this molecule. So it is very tolerable, just a tablet. So imagine a tablet where a metastatic cancer, we have no options, providing so much of response rates. So MSI high, I'm going to touch about it. It is nothing but molecular instability, microsatellite instability. So this microsatellite instability or MSI has actually redefined the way we treat many solid tumors. So four particular proteins are tested by us in IH, which is the simplest way to do it, but we also can test for the microsatellite instability in the genes. So all of us might be aware of the MLH1, MSH2, MSH6, PMS2 or EpCAM, which constitute the Lynch syndrome, and one of the most common reasons why MSI can be high. And these again are tumor agnostic. We can see that endometrial, small bowel, CRC, bladder, skin, GI, sarcomas, and even cups can have variations of MSI high rates. And once a tumor is MSI high, the response rates to immunotherapy are really, really good. So look at this, just one column here, the median overall survival for a patient with MSI high and more than two prior therapies. So someone who has progressed on two therapies for colorectal, and we are still able to give them around 2 to 3 years of median overall survival just by picking up this MSI high, and that is really good. Cholangio, none of us talk about survival for more than a year or two in metastatic setting, and again here we have 2 years of survival. For endometrial and cancer not reached, so that is again very important. So there are trials going on irrespective of the tumor site. Just picking up the biomarker and treating is the future. So these are the trials for different sites, irrespective of which site it is based on MSI high. The response rates again are something to watch out for. So tumor mutational burden is nothing but mutations per megabase of a genomic sequence. And these mutations create neoantigens that can trigger an immune response. So high tumor mutational burden may be a biomarker for immunotherapy response. So this is something again irrespective of the cancer site. If we pick up a tumor mutational burden, we can treat it with immunotherapy. And Keynote 158 is the trial where they said any solid tumor
with a tumor mutational burden of more than 10, you can go ahead and give immunotherapy. And again, the response rates are almost 50 to 60%, and we can see that patients definitely have a better median overall survival. So HER2, so that is one thing which we are very aware of, mainly in breast. We all use our HER2 testing judiciously, but HER2 is there in other tumors like cholangio, salivary gland. You can see it in even breast, you can see it in lung, you can see it in colon. So these HER2 mutations are also becoming tumor or tissue agnostic, and we are able to treat it with very good drugs, especially trastuzumab deruxtecan is going to revolutionize the way we treat breast cancer, and we can see amazing response rates as we see in the waterfall plots here. So NRG fusions are the other ones, the uncommon ones. So we'll skip that for now. And what we need to remember is MSI high, tumor mutational burden, HER2, and NTRK and RET. If you're able to just list these, if in a question asked what is the benefit of CGP in any metastatic patient, listing those itself is very, very important. So in the world, as we speak, there are many clinical trials going on irrespective of the tumor site. In that, I've picked up one. This is the TAPER study, where this is going on in the United States right now. And look at the study design. So they're just taking one treatment and going and doing a CGP, finding out what mutation is causing it, and in different tumors they're separating the patients into different cohorts based on the genomic alteration they found. So if you look at the TAPER study, there are 17 treatments. So these are the trials that are being designed as of 2023. So 17 treatments which are being given for 85 plus genomic targets. So it doesn't matter what the patient has, which cancer the patient has, the patient just needs to have a comprehensive genomic profiling report, and they're being enrolled into the TAPER study, which is going on currently. They had presented this study in ICC recently, and they were showing very good responses in at least certain cohorts of patients. So like the TAPER in the world, we need to know that histology agnostic trials or basket trials are going on. And just to name TAPER, tapestry, precision, determine, if we need to read about in depth about any of these other clinical trials going on across the world. So the key takeaway, to ensure that patients with solid tumors who could benefit from histology agnostic therapies, it is essential to identify the biomarkers. Unless you identify, you can't refer for a clinical trial, you can't treat the patient adequately. So this is the last couple of slides. As we can see here, victorious warriors win first and then go to war, while defeated warriors go to war first and then seek to win. So having all the information about our primary enemy, which is cancer, in our clinic, and then going to war with it, increases our chances of being victorious many folds. So that would be my last slide, and I would be happy to answer the questions now, and I'll just go through the chat box to see what are the questions that are there. So I have a question here which says, when multiple mutations are detected by NGS during whole genome sequencing, how do we determine which mutations are actually significant and which are not? So that's a good question by Dr. Abhishek. So we are not yet doing whole genomic sequencing. We have picked up that a few hundred cancer-causing genes are there amongst the genome, which are responsible for most cancers. And this particular few hundreds of genes are the ones which we are sequencing at this point. But what we are doing now is we are sequencing the whole gene and not just a hotspot. So that is very important. So even the most comprehensive panels pick up the few hundred cancer causing genes and do it, not the whole genome sequencing. So once we have a genetic report, there are small parameters which help us decide which is a pathogenic gene. Firstly, once you sequence, you will know that 1, 2, 3 are the pathogenic variants, and based on these information, we tend to incorporate this into arriving at a pathway which is currently acting on the cancer and driving the particular cancer. So what I mean to say is, what is a driver mutation, what is a passenger mutation is indicated in the report based on the variant allelic frequency and other parameters about which particular pathway is activated is there. Then we decide which particular gene needs to be targeted at the beginning and which particular information we can keep for later lines of therapy. So to summarize that one question by Dr. Abhishek, it is basically you have all the information, then you sit in the molecular tumor board, discuss with the molecular pathologist to find out which of these mutations is driving the cancer, and you treat that particular genetic mutation first and keep the rest for later. So that I think answers that question. And so which NGS platforms are available in India and what is your experience with them? So there has been, I think, a boom of different companies using NGS platforms to do CGP. So NGS platforms are not different. NGS platform is one. Different companies use this particular technology to come up with different tests which are comprehensive genomic profiling, and that which company, what is your experience with them is that I think at the moment, what is very important for every clinician at this point, when we are picking a particular lab, in Bangalore itself, there are 15 to 20 labs who do it. When picking a particular lab, we need to look at three particular things. Do they have analytical validation? Has their testing methodology using NGS been validated? Then clinical validation. Then you need to know whether they have published any of their comparative data, whether they have compared it to another FDA approved test, and have they published it in any peer reviewed journal. So having this validation in your head about which lab you're going to choose is ultimately going to come with experience, and there is no one lab which suits all. So if we are talking about FDA approved, there are a couple which have been there for the last 2 decades. Picking those would be a safe option when we are dealing with a tissue or a tumor which is not responding to therapy. But experience with Indian companies comes over time, and there is not one which is going to answer all questions. So if CGP shows multiple genomic mutations, how is it decided? As I just discussed, you need to have a tumor board, arrive at which is the driver, and then treat the driver. So how can we decide in sending CGP in various cancers? At this point, ASCO guideline is there. In a metastatic setting, post 1 to 2 lines of therapy, you are eligible, or every patient is eligible to send for CGP. Whether you act on the information or not is the next point, but getting all the information in the second line or first line metastatic setting is, I think, the prerogative of our discussion here. So having the information, and if we find something which we feel that treatment is going to be better than our regular chemotherapy or the conventional therapy as indicated in our textbooks, that becomes the most important point. So how to plan CTC NGS in newly diagnosed fresh cancer case? See, NGS on CTCs is still kind of premature. They're doing it on the ctDNA. Very few of them are doing genomic sequencing of the circulating tumor cell. That is the future, as you have correctly asked. But at this point, they're doing it on the circulating tumor DNA, and especially lung cancer. Even NCCN and ESMO have actually said when tissue is not available for tissue-based comprehensive genomic profiling, so a liquid biopsy or an NGS on the circulating tumor DNA can be used, and this is known as a liquid first approach. So the next one, how does one decide on ordering somatic versus germline testing? So that is a very important question. As we know, a germline mutation usually would be present in all the cells of our body. It is present in all the cells, including the tumor cells will have that particular mutation. So once we get a report of a somatic testing and we know that variant allelic fraction is high, more than 30, more than 40, that means most of the cells, cancer cells, have this mutation. And depending on the clinical history, age, and what cancer we are talking about, sometimes we go ahead and do a reflex germline testing to see whether the blood cells or the buccal mucosal cells also have this mutation, thereby doing it in a reflex manner after we get a somatic test. Or if a patient walks in and says, I have many first degree relatives with a particular cancer, and like breast cancer or ovarian cancer, and the patient walks in, you're very sure that there's a strong history and the patient is in the 4th or the 5th decade of life, you can directly order a germline testing also. So it depends on clinical history and it depends on the cancer. There is definitely no guideline which covers all the cancers when we are deciding on ordering a somatic versus germline testing. So then I think we have covered the liquid or CTC NGS. Liquid is basically uses circulating tumor DNA. CTCs are identified but not yet sequenced as every cell. And in upcoming time, will it replace tissue NGS? Yes, we are getting closer. None of us were confident a decade back about using a liquid biopsy, but in 2023, we can say that there are labs which claim to be 90 to 95% concordant. So what is the volume of tissue needed to be sent for NGS? It is again depends on what particular test we are ordering. If you're ordering CGP, they will need adequate tissue, and it is not the tissue, it is the tumor fraction in the tissue which matters. Just having a lot of tissue with less tumor fraction doesn't help them get better results. So what ideally should be the pathway here, once a biopsy is taken, the pathologist in our hospital will look at the tumor fraction. Once the tumor fraction is more than 20%, is what most labs ask for, that is being validated by our pathologist, and from that point that particular sample can be sent for genomic testing. So I think in poor prognostic cancers like gallbladder, which do not show much good response to chemo, so that is, I think, very important. So in gallbladder cancers or in cholangiocarcinomas, the treatment paradigm in metastatic setting has completely changed. So you won't believe it. So CGP has an extremely important role in gallbladder and cholangio. Now we are looking for around 6 mutations at presentation in a stage 4 for gallbladder, and this can be only possible with a CGP. We are looking at HER2. There is very impressive data coming out about using anti-HER2 therapy with better survival in gallbladder. We are looking for IDH1 mutations, FGFR1 mutations. We are looking for NTRK. We are looking for MSI. So these 5 or 6 in gallbladder and intrahepatic cholangiocarcinoma is definitely going to make us move away from chemo. As you have correctly said, the response to chemo in these hepatobiliary is on the poorer side. So I'm going to take the last 2 questions. So when to order for somatic gene testing and when to order for germline, I think we have answered that. So for immunotherapy, which is the specific marker, PDL1 or TMB? So that again is very important question. So PDL1 is an IHC. We are looking at the programmed death ligand on the tumor cells and the tumor microenvironment using immunohistochemistry. So basically we are looking at proteins. Tumor mutational burden is a genomic test where we are seeing what are the number of mutations present in the DNA per megabase, as we just saw the definition. So there are 2 different tests. One is PDL1 is protein level, TMB is genomic level. So at this point, TMB is available only if we do a comprehensive genomic profiling. You can't do a small 10 gene panel and say I want tumor mutational burden. It is only possible for a lab to give the value of TMB only when we do at least 100 to 200 genes are sequenced and we know the mutational burden, and then we can come to tumor mutational burden. So for that to be put in the report, we need to test for so many genes. So PDL1 and tumor mutational burden are equally important, but I would say PDL1 is much more easier for us to obtain because it is just a immunohistochemistry. So again, opinion on TPS, CPS and its platform